professor at Stanford, a professor of pediatrics, a professor in psychology, a professor in psychiatry, that I have known a long time. And I will tell you that, jokes aside, I was very concerned about Korey Hood in the early 2000s. One of his mentors, in fact, his major mentor is Suzanne Bennett Johnson. And Suzanne used to ask me to sit on promising a thesis committee. And she said to me, this will be a little tough one. He doesn't get his work done on time, but you'll enjoy him. He's a really, he's got a lot of potential. So I said, okay. And Suzanne was right. This guy was late. It took him forever to get his thesis in on time, seriously. And I said to Suzanne, hey, you've given me a few, is he going to make it? He said, trust me, he's going to make it. Well, I want to tell you, has he made it? I think that Korey is one of the leading, if not at the forefront, of child psychologists in the field of type 1 diabetes today. Really, everybody wants him on their external advisory boards. Everybody wants him on their theses committees. Korey has made it. Korey is internationally recognized. He has deserved it. He has earned it. He is incredibly well funded. He's been funded by the NIH. He's been funded by Helmsley. And his work really revolves around behavior, positive outcomes, improving the lives of patients with, type 1 diabetes. And really over the past few years has made, not that he needed it, a name in trying to understand the impact of technologies and the experience that kids, endure on a day-to-day basis. He is really the author of well over 150 manuscripts. He's written 2 books. He's really one of those go-to people and really the epitome of a team collaborator. So, I will tell you that he has met deadlines. I've even seen that through a collaboration that we did recently. So, I have to believe Suzanne when he said this guy has great potential. And so it's with great pleasure that I introduce Korey Hood to speak to us today. Thank you.
Well, thank you, Des. That was definitely one of the nicest introductions I've ever had, and I really appreciate that. And I think that when I think about my time at Florida, a couple things jump out at me. It's, starting work with Suzanne Johnson and, getting kind of the enthusiasm for doing this work, and then meeting you and shadowing you in clinic and just feeling the, I don't know what you might call it, the energy, the passion in helping people with diabetes. And so I appreciate your support then, I appreciate your support now, and it's really nice to talk with everybody today and kind of be back and part of this the UF program right now. And I do wish that I was there in person. It would be nice to see everybody and interact, but we'll like Dr. Atkinson said at the beginning, we'll have this as a placeholder, and then hopefully we can I can get there and we can interact and do some work together. So I'm going to share my slides and then get started. So hopefully you can see that. As I'm going along, if there's any issues with sound or slides, just let me know and I'll adjust. I want to just kind of note a couple of disclosures at the beginning. I don't think any of these present any conflicts of interest, but I always like to point them out. Some work I've done with several different groups, for-profit groups around behavioral aspects of diabetes. And then you'll hear a little bit more about some of the work that we've been doing with diabeteswise.org, which is, we created that, and it's with support from the Helmsley Charitable Trust. So it's a not-for-profit enterprise, but you'll hear a little bit more about that as we go along. So I have a couple of objectives that I hope to achieve as we go along today. And one of them is to convince you that health and quality of life outcomes are equally important for people with diabetes. And the second part, and you heard Dr. Schatz talk a little bit about this, is thinking about how we can utilize devices, technologies, telehealth to promote both aspects of outcomes, health and quality of life. So what are the ways, or what are the how can we take advantage of these great tools to improve outcomes for people with diabetes? So I like to start here because this is these are the two that I probably spent the most amount of time with over the last couple of years, and we're going to talk about telehealth and connecting with people. So there's been a lot of days with these guys, and there's a chance you'll hear one of them stomp through or something as we're talking today. But this picture in particular also makes me think, you know, as I'm presenting and as we're delivering these things on Zoom, the sun on the left it's kind of like what we're supposed to be when we deliver it, where we're supposed to be enthusiastic and upbeat and excited about what we're doing. And then I think the one on the right is a little bit about what happens when we're watching it, where we're kind of sometimes feeling like we're just staring into a dark hole. So I appreciate everybody connecting today. I appreciate everybody being part of the presentation. If I know it's across your noon hour, if you need to walk around or do whatever you're doing, do that. I'm sure that the weather's beautiful there, so I'll do my best to keep you engaged. So as we talk about outcomes, I think one of the first parts is really to think about what do we know? And I'm not going to say anything that you don't already know about outcomes. When we look at data in type 1 diabetes, we can point to the type 1 diabetes exchange, and we see only about 17% of youth and 21% of adults meet the ADA targets for A1C. We've expanded how we think about some of the glycemic outcomes, but this is still not acceptable. It's a sobering level of outcomes that we're achieving at this point. And then when you look at it kind of more broadly, and I think in particular with type 2 and kind of the whole landscape, a paper that was published in 2018 in JAMA Internal Medicine, I pull out the conclusions here. And a couple of points. One, that the cascade of diabetes care in the United States hasn't significantly improved since 2005. And that in particular, for younger adults, women, and non-white individuals, that these inequities or these disparities continue to exist. So we've worked really hard at patient-centered care, personalizing care over the last couple of decades. It hasn't yet resulted in improved outcomes at the population level. So what do we know about the key drivers of diabetes health outcomes? When we think about outcomes such as A1C, which has traditionally been thought of as the gold standard, but certainly with time and range, the development of complications, other areas, what are the key drivers? We can probably classify them across a few different categories. This is work that I was part of with the team at Cincinnati Children's, looking at what really promotes self-management behaviors. And you think about, the individual, family, community, healthcare system. There's a lot of influences on these health outcomes. And when we also look at, this is a pie chart that was published in 2007 in the New England Journal, where they were looking at the proportional contribution to premature death. And the reason for this at that time was thinking about healthcare and how important is it to healthcare. And there's not as much of an emphasis on that, but you see that we have some ideas about what causes these different outcomes in individuals more broadly at the population level. So switching gears a little bit to quality of life, when we think about quality of life, self-reported assessments, surveys, distress, all these, and I'll tell you a little bit more about that in a minute. But what are the key drivers of these quality of life outcomes? we can use the same images to really predict and to see what are the key drivers of quality of life, as we know with health outcomes. We know that they're very similar. They're rooted in individual aspects, family, community, healthcare system. All of these have an influence on quality of life like they do with health outcomes. And while, again, this is specific to a health outcome, the likelihood that these things track is really high, especially when you have such a high overlap with behavioral patterns. So as I'm telling this story about the importance of quality of life, let me just define it a little bit more. I'm using it here as a kind of an umbrella term to talk about a number of different areas: diabetes distress, conflict, communication issues, fear of hypoglycemia, fear of hyperglycemia, resilience, some of the positive aspects of it. So when I'm using this term, I'm thinking about it in a kind of a broad way, and I'll tell you why I think it's important for us to talk about it that way. So when we think about health and quality of life, health indicators have long been viewed as more important than quality of life. Certainly when we look at it from a regulatory standpoint, but also when we look at what happens and what's the emphasis, administratively and budgets, that health and the medical care side has long been valued at a higher level than the behavioral side or thinking about quality of life. So, but I do want to argue that an approach that targets both has the potential to optimize more than just health. And one part of that, and I'm going to give you an example, is with problem solving. Really can become a critical skill to teach. This is some work that my colleague, Jill Weisberg-Benchel at Lurie Children's in Chicago, that we completed about a year and a half ago, where we followed almost for 4 years after we gave an intervention to teenagers with type 1 diabetes. And we gave them this program that Dr. Weisberg-Benchel had adapted, and then we tested it in a large RCT. And what you see here is what the levels are of diabetes distress over time. And the solid line is the control group, and then the dotted line is the resilience program or the problem solving program. And you can see that over time, they start separating and they get even further apart over time. And this is clinically and statistically significant because we taught them these skills early on. And you can see on the right side, what are the things that we taught them? We taught them to apply resilience skill. We taught them problem solving, assertiveness training. All of these different aspects of it were critical parts to teach them early on. And then it wasn't just distress. We saw, and this is partly why I argue for this bit of an umbrella term, is we also see these effects on things like depression. And we followed these youth, and some of them were now into their early 20s. And we saw them with depression. You see it kind of separating, and again, the dotted line is the resilience program, that their distress and their depression continue to go down over time. And so we think that there's a positive impact that teaching these skills early on can really have. And so one of the reasons I think that the health and quality of life outcomes haven't always been viewed on the same level is that sometimes it takes much longer for these effects to be shown on the quality of life side. Some of the skills that we're teaching early on don't quite show up maybe as rapidly as some of the glycemic ones that we're expecting. So how do we put this on the same level? I think that one strategy is that, certainly from quality metrics, NCQA, and then thinking about payers, that if we can continue to impress upon them how important this is, and you can see over the last 5 to 7 years, there have been more and more of these kind of quality of life indicators that have worked themselves into reimbursement models. And I think that that's a positive direction, and we can continue to push that. We worked with, this is a collaboration with Dr. Lori Lefel and others to create the Inspire scale. And it became the first FDA recognized medical device management tool, MDMT, outcome that can be used on device labels. And so we were pretty excited about being part of that effort to have aspects of quality of life be part of the regulatory process in a much more formal way than it has been. And then I won't hit so much on this today, but I do want to argue about 4 mechanistic models, thinking about what are some of the key drivers and when to deploy them so that we can both have improvement in health and quality of life outcomes. So we have some work that we're doing now on that, and hopefully we'll have more to talk about in the future. So let's switch gears just a little bit and talk about telehealth. So I think that as I put in the early objectives, knowing how to utilize something like telehealth, I think is really important for us. So this was a publication in JAMA in 1997. So, we've got almost 25 years ago, this data was submitted. And when we look at what they thought about from, and at the time calling it distance medicine technology, they found in this large systematic review that there were significantly improved outcomes in studies of a few different areas, but also including diabetes care. So even at this time, there were a number of trials that were already being conducted to understand how we can utilize telehealth. And there were positive effects 25 years ago and before using this kind of technology to reach people with diabetes. So what are some other reasons why we want to look to devices and technology? This is some data. These are some data from the Pew Research Center published a few years ago, where they asked adults in the United States, what's led to the biggest improvements in your life in America over the past 50 years? And you can see overwhelmingly on the left side, people talked about technology, 3 times more than any other category, but the next category was medicine and health. So people are really viewing technology, medicine, and health as things that drive improvements in the quality of their life. And then when you ask them similar questions about what they think is going to make those the most dramatic improvements over the next 50 years, people talk about technology, medicine, and health. So people are primed, not just people with diabetes, but the population is primed to receive care services in a manner that is consistent with what they believe, what their attitudes are, which is technology, medicine, and health are going to be the things that really improve my overall health and quality of life. So what do we know? And if you logged on, Dr. Schatz was talking a little bit about just how much things have changed over the past 5 years, but particularly in these last couple of years. But there's a paper that came out at the end of 2020 about kind of a bit of a review of what's going on with telemedicine around the world and what has changed or what's been emphasized due to the pandemic. And I wanted to pull out a couple of points here. Their main conclusion is that there's increasing evidence to suggest a positive role in improving health systems performance and health outcomes using telemedicine. But as we know, there's significant variability by country and global regions. And I would encourage you to check out this policy brief in Frontiers in Public Health and look through Table 1, because it really talks about the areas that have the most need for us to work with them and to kind of share the telemedicine wealth that we have, or the infrastructure that we have with other countries. And one of the other takeaways for me was that we can't let the enthusiasm for telemedicine, telehealth, for utilizing care in this way, we can't let it return to the pre-COVID ideas and innovation. We've got to capitalize on the enthusiasm that's going on right now. A couple of other examples of this work, and examples, and then also a call out to some additional needs. When you look at, there was a paper that was published in Diabetes Care in June of this year from the Vanderbilt pediatric team, and what they looked at is as people transition from in-person to telehealth care based on need at this time for doing it, across about 30,000 patient visits, the odds of completing a visit by telemedicine were lower among non-English speaking and Medicaid insured. So there were people that were left behind because of these kind of non-modifiable characteristics. But overall, people were really receptive to this, and there was high satisfaction with switching to this. But it points out that even as we try and transition, we can't leave individuals behind. There need to be additional efforts to make sure that everybody is brought along at with the same access. One of the papers, and this is from Dr. Ashby Walker here and Dr. Mike Haller, who we've collaborated with on Project Echo, and the team at Florida really has been driving getting a better understanding of what these underserved communities really need. And this paper that was led by Ashby and was published in July of this year really speaks to a couple of needs. And I think I put the results here to emphasize a couple of points. One is people aren't typically going to see an endocrinologist, and there was a lot less technology used based on a few different factors, including SES, race, ethnicity, and there were also some regional differences. So to me, this highlights continued need for work that we're doing, but also that when we think about models where we can reach people remotely, we need to consider that potentially as a hybrid approach to the in-person care that we're doing. So switching gears a little bit, but still in the technology realm, thinking about some of the devices. And I think that individuals on this Zoom are really familiar with these parts of it, but maybe we categorize for anybody who needs insulin, type 1 or type 2, maybe two main categories at the top, kind of the foundational parts of diabetes care. You've got to get your insulin, and you've got to know your glucose. And then we think about some of the more advanced techniques down below, and I've included insulin pumps, although right now they probably feel a little bit antiquated because they're limited by some of the aspects of insulin that's used in them. But certainly when we think about closed loop and continuous glucose monitoring, and I think in particular CGM has really been a major game changer over the last 5 to 7 years in terms of what we're able to do. And then we think about closed loop or the kind of integrated automated insulin delivery systems. So there's a lot that is being done and a lot that's being worked on, and there are some things that are left out here. This is purely on the delivery of insulin and knowing your glucose side. And then, so what do we know the evidence for those devices? Certainly insulin pumps can lower A1C, even if it's a kind of clinically modest or amount, it can, but we also see pretty large improvements in quality of life. People feel more flexibility. This is particularly true, I think, in the pediatric setting. Insulin pens, which are, you can see, this is a growing area where you move people from syringes and vials to insulin pens. You can see increased frequency of injections and also satisfaction as we move to something like pens versus vials. So even that kind of small amount of technology change can have a major impact. And then when we think about closed loop, certainly we're seeing with more and more publications on this, improved time and range, patient-reported outcomes. And then on the right side, checking glucose, we know that if that's the foundational part of diabetes care that's being done, doing it more can lead to better health outcomes. And then on the CGM side, really you can see improvements in time and range, A1C, and especially with these more recent generations, significant improvements in quality of life. So with that said, there are barriers to this, and this is a publication we have in diabetes care led by Dr. Molly Tenenbaum a few years ago, where we asked over 1,500 people with type 1 diabetes, what are the main barriers to using these different devices and technologies? And you can see up at the top, cost of supplies, cost of the device, insurance coverage. These are things that rise to the top. And I think that it's only becoming more pronounced as we ask more and more people about what are the biggest barriers to using these devices and technologies. Cost, coverage, these are things that we can't ignore, and we've got to find more ways to deal with them. Some of the things that maybe we as maybe in the interventions that we design that are rolled out in clinics or delivering direct care, thinking about helping people understand better. It's thinking about, a lot of people talk about the hassle of wearing devices. They don't like having devices on their body. So these are things that we can help people with in real time as we're working on some of those other kind of larger cost access issues. People talk a lot about when we ask them about discontinuing CGM, and these are similar results that you're seeing in some of the more recent publications. People don't like the alarms. They're not always sure that it's accurate. Even if we tell them that it's accurate, people don't believe that it's accurate, and we need to pay attention to what people are telling us. And then thinking about pumps, it's painful, it's uncomfortable, don't like having them on their body. So there are a lot of things that we can work with people on to keep them on these different devices. So integrating these couple of pieces, so thinking about devices, thinking about telehealth. This is a slide on the kind of the virtual clinic or remote clinic model. There's a pilot study that I was part of that was published and led by the JABE team in Tampa about what ultimately happened was people with insulin requiring diabetes, adults with insulin requiring diabetes, were started remotely on CGM and provided all the support, education that they needed remotely. Never had an in-person visit. And we found beneficial glycemic and quality of life in this pilot study. And so in the fully powered trial that's going on, and it's fully recruited now, Cecilia Health is a group that's managing the cases and CGM and the delivery of from a CDCS. And then we implemented the behavioral screening aspects. And what we're finding is 57% of individuals are screening into our services. So some significant clinical need for behavioral support. And the ones that rise to the top are things like diabetes distress, fear of hypoglycemia, and problem solving. So we think that both this can be an effective model for delivering this care and having an impact on the health side, but also on the quality of life for the behavioral side. And there'll be more published on this in 2022 as we're just wrapping up the trial right now. And then one of the last things I'll talk about on the telehealth side is we were recently asked to, or invited to write a comment on telehealth for people with diabetes and thinking about a bit of a new approach in Lancet Diabetes and Endocrinology. And one of the areas that we emphasized, some of the same things that I've talked about, but really when we think about an approach that allows us a little bit more of a window into where management happens more of the time, that may even be beneficial to us as providers of care, and thinking about designing interventions, designing problem solving, goal setting for individuals with diabetes, and the reclaiming of time that they have by not traveling to visits can be a real benefit. And so I think that there are some reasons that a hybrid approach of delivering care this way can be really effective. So in summary, and when we think about telehealth and devices, and then I've got just a few more slides on a related topic, there's high interest, high expectations for telehealth and devices. And technology in general. Telehealth is really a desirable alternative or adjunct to in-person care from the perspective of many people with diabetes. and that utilizing devices, particularly CGM, can be a really beneficial aspect, the kind of telemonitoring addition to telehealth or remote care. And I want to just reemphasize that disparities need to be addressed in these situations and not created. I think that as we continue to push forward, there's a real potential for us to create new disparities or new gaps in access and utilization that we have to be mindful of, and to be thinking about it both at the individual level and then at the kind of larger clinic system or population level. So I'm going to tell you just for a couple of minutes about some of the work that we've been doing on Diabetes Wise and the provider version of it. The partners that we have for this, obviously I sit at Stanford, but the funding for this has largely come from the Helmsley Charitable Trust. And then we partner with HealthMade, which does a lot of work on user research and design, has a number of individuals in their group with diabetes or that have done a number of diabetes projects, and then Upshift as well, which is kind of our technical partner. So what we saw as the problem was that we didn't think there was an unbiased resource to promote uptake and optimal use of devices. And we didn't think there was really an easy way for people, or for more broadly for people to have increased device awareness using free tools that engage, nudge, improve outcomes. That really what people had to do was they had to look at different options. They had to ask clinicians. They had to do a lot of their own research to try and understand what might be the best fit for them and their lifestyle in terms of diabetes devices. And so, and also thinking about this idea of device matching. So what fits best with their life? So we created Diabetes Wise, and it's a digital space. We think that it's unbiased. We don't push one device or product over the other. We certainly have a bias toward helping more people get on devices. We think that they can be really effective and really helpful. So we have that bias, but we don't have a bias toward one over the other. We created this with people with diabetes. There are a number of people, including myself, on the team with diabetes, and we really aim to ultimately improve outcomes in this situation. So as I mentioned, what we think of as the value proposition on Diabetes Wise is for patients to have more awareness about different device options. The professional version, so for providers, we think you can streamline education and improve how they both match devices and think about prescribing devices for people. So some of the work that we've done on it, we have on the landing page for Diabetes Wise, people can do a checkup, which captures information about current device use, distress, priorities, concerns, and then takes them on a tailored or personal journey through the website, and different stories are available, experiences that people have had, as well as what might fit them, what other people say about what fits well with their kind of concerns or their interests. We recently completed a study on 458 people with insulin requiring diabetes. About 80% of them had type 1, 20% were type 2, all adults, but a large majority of them were on injections and very few were using CGM on a regular basis. So this is really the group that we're targeting, care outside of specialty clinic. What we saw was in the first month, we were able to, just by use of Diabetes Wise, just by people having access to it, and we had a cloned website so that we could track everything that they were doing and where they were going on it. But a quarter of them within the first month initiated a discussion with their provider about the devices. So we started to kind of raise awareness early on. And then even 6% in that first month started some new device through just becoming more aware of it. And you can see across the 3 months or the entire study, this really low intensity intervention kind of generating awareness for people, led 50% of the sample of these 458 people to having a discussion about it, and a quarter of them started a new device. So even a low intensity program like this can be something that starts people on their journey to being interested in these different devices. And so the provider version will launch next month. And again, when we think about the provider version, we also didn't think that, especially as when you think about adults and a high percentage of them receiving diabetes care outside of specialty clinics, you can see that there's a need for both the providers and patients to kind of become more aware of different device options, and then to move toward the process of prescribing. So on the provider version, you can do a compare devices feature where you could, and these are just examples here, again, not pushing any certain product or device, but you can compare kind of the two different CGM, and you can do it across device details. You can see what the difference is: affordability, access, the data view, duration, storage. You can see patient considerations, which, if you're thinking about your patient who's really interested in having an active lifestyle, which one might fit them better. This is really a feature that I think all of us use. Anybody who does anything, where we buy something online and we see other products like this and we want to compare different features. So people are used to being able to compare different devices in this way. And traditionally, both patients and providers have had to go to different industry websites to be able to compare these in real time. One of the other things that we've realized from a number of work with providers and some user research is that even if we help providers become more aware of different device options, they're not always able or ready to prescribe. And so one of the features that we wanted to create was a prescription tool. And you can see here, and again, this is just one of the devices pulled up, where you can enter the device that you're interested in. You can either select Medicare, Medicaid, you can do a private insurance, which there are hundreds of them, and then you can get tailored information about what you need to do for that particular device. There's authorization, what parts of authorization will that insurance cover it? And we're working also to make this more specific state-wise, because we know there are a lot of these kind of little wrinkles, particularly in a big state like I'm in California, Florida as well, is a large state. But when we get into the county level coverages from something like Medicaid or Medicare, there are a lot of these little wrinkles that I think are important for people to understand. So our hope is that this becomes a good tool for providers to use as they work with patients and make it easier to prescribe these different devices. And this is just it's a little bit hard to see here, but there are certificates of medical necessity that auto-populate from the different manufacturer, different codes that you might need for prescribing. And so we're hoping that this can be a really helpful tool for people as they move forward, and not just creating awareness, but then an actual prescription or movement for the patients that they work with. So to wrap up this section on Diabetes Wise, I want to just note, when we think about engagement, we've thought a lot about how to make things person-centered and also to have personalized experiences. And there's still a lot of work to be done, but I think that that's really the direction that's going to promote the most uptake, awareness, and then use of these different devices and even telehealth. And I think that what we found is, and I don't think this is surprising to anybody, but the power that other people's stories have and other experiences that people have with diabetes, their experience of starting, stopping a device, using telehealth, not using it, is really powerful for people. And we think we can, this is a way to both educate and to help move people along and become more comfortable with it. And then, as you see, we're trying to understand better ways to increase knowledge and skills, and we think that these are some of the tools that can be used. So to wrap up, I want to just say, I think, as we think about integrating this into some aspects of care, I think it's really important to talk about devices and telehealth early, both in the disease course as well as in our interactions with them. If someone's coming to us after having diabetes for 10 years or other situations, it's still important for us to talk about them early in our work with them. And certainly thinking about ways to systematically assess barriers to use, collaboratively use problem solving. There's a lot of benefit of using something like motivational interviewing to understand what's gotten in the way in the past and how we can help life that we do as we do with health outcomes, and that we partner as needed in these different situations. There are a number of clinics that have in-house behavioral psychological support, but there are a number of clinics that don't. And so finding ways to help providers have access to partners in this process is really important. And then thinking about advocacy efforts, many of the questions that arise when we talk about these things are, what are the ways that we can get reimbursed? What are the ways that we can get paid for telehealth devices? And so there's a whole parallel effort or related effort that we have to do around advocacy and pushing both payers and regulators. And I think at the clinic level too, within these systems to think about reimbursement models. So I hope that as I wrap up, I've convinced you that these are, there's still plenty of work to be done. There's plenty of work on the quality of life side in terms of providing or developing interventions that have a robust effect, both on aspects of quality of life, but also health. We need to do more in this area. We're not done. And then thinking about how we can utilize these different devices and technologies and telehealth to really improve outcomes. So with that, I thank you for your attention, and hopefully you were more on the excited side than the staring into the deep, dark abyss as I presented, but I appreciate your attention and appreciate the opportunity to chat today.
Korey, that was fabulous. Absolutely fabulous. I know Mark has a question, but he's going to have to wait until I've asked a question, and then we'll, get things. Korey, what you've said is incredible. Stanford is lucky to have you and your team. We're sort of lucky to have Kim Driscoll, Sarah Weston, and her team. But I will tell you that we don't have enough. I mean, what you're saying is things that we have to do. Even here, we can't meet the needs of our patients. And, particularly during COVID, anxiety, distress, depression, we have a bottleneck. And, it's sort of one thing after another, from quality of life, which has been impacted, all the way through to the resources needed to educate people on technology. So it's not, although you presented them separately, they're actually integrated. They're all part of how it is, and it's been on the patients, the providers, the whole health system. So as I see you providing, potential solutions, I'm concerned that we won't be able to implement some of these what I think are very good solutions because of a workforce issue and really a challenge to our healthcare system. So I thought, let you comment on that, and then I know Mark has a question.
Yeah, I think that, I think you described the problem really well, and I would say a couple of things. One is I don't think I don't have a solution. I don't know that anybody has a solution that captures all of these different areas at the same time. I think that doing work within each aspect of it helps push. So, for example, on the equalizing some aspect of quality of life with health outcomes, pushing for within clinics, within programs, within systems, screening for distress and depression. These feel like basic things, but a lot of places don't do this, and a lot of places don't do this on a in a systematic way. So I do think that there's some efforts that can be made within each area that can help push it forward. From a consolidated way, I think we have to look at some other alternatives, and thinking about other groups that can help offload some of the care, which again may not be as appealing to administrators, because some of the cost doesn't immediately come back to you, or some of the but I think that there are some ways to think about how we can partner with other groups. If we look at what's happened, and this is even pre-pandemic, the movement of people going to something like BetterHelp or Talkspace or these online resources for receiving mental health care, this has been just growing, and people are becoming more and more comfortable with receiving that support. We could argue about the quality of it, but receiving that support through text messaging, through infrequent coaching, through different strategies. I think if we don't adapt a bit with the way that we deliver care to having some of those aspects, I think we're kind of destined to be left behind, because we have to find ways to make that work high quality, because right now it's okay quality, but I think that we can do some more on that. So that's it's a little bit of a wondering answer to your question, but I think it's a few different areas that I think we have to prioritize. And one of those is thinking about these additional adjunct services that we can bring on that really feel like a bundled model of care. It's like people have access to this. I'm still delivering their care. I'm still their primary provider, but you can access this person for coaching, and it's all part of what we deliver, all part of what we do. And I think that those are going to be more appealing approaches to people as we move forward.
Thank you. Yeah, Mark, you had a question.
Yeah, thanks. Korey, I agree with Des. Amazingly current talk and great job. Appreciate it. So if we agree that with the perception that in the last, say, quarter century, biology, which most of what I do and some others has underperformed in terms of impacting patients relative to technology, in your first part of your talk, you described a love-hate relationship, meaning where it seems like people hate technology, but at the same time they say this has been the greatest thing since sliced bread. Do you know anything on the horizon that's going to close that gap? Meaning, are there technological advances in the pipeline that will at least maybe cut down on the I don't want to say hate for technology, but from what do you know what I'm trying to ask?
Yeah.
I mean, is there something? Yeah.
No, I think it's a great point and great question. I think that there's a tension, I believe, where people feel like, and maybe the word is burden, when technology or technologic fixes actually generate more burden, and this kind of balance between the benefit and burden is there's not enough benefit and there's too much burden. I think that that's what really drives people to feel like these things aren't useful and can steer them away from continuing their use or starting their use. And I think you see that in a couple of different segments of the population. Certainly people who are less technologically savvy, and I don't like that term so much, but I do think that people who are not comfortable with daily use of technology, I would think of them as kind of the less tech savvy. And so we've got work to do, I think, to push individuals in that category toward becoming more comfortable with it. the digital natives, everybody who's, I don't know what the age is right now, but anybody who's 25 and younger is a digital native, and those individuals see solutions in that way, and so even if they don't like it, they're still going to use it, which is a different problem than individuals who aren't comfortable with it. So my guess is a long-winded way of saying, I think there's a few different subgroups, and we need different solutions for those different subgroups to kind of push them over the kind of threshold for being interested in doing it. What I will additionally say is that there are a number of just systemic issues that create barriers or create gaps in access and utilization that we also have to address. So there's probably that at the same time as thinking about these different subgroups. That's my initial thought on that, but we have plenty of work to do in this space.
So I guess I have a follow-up question based on your answer is that let's take cell phones, whether it be it Android or iPhone, are there lessons to be learned on how these became so integrated in life and acceptable, meaning people may complain about service blackouts or holes, or I get too many text messages or whatever, but is there something that cell phones did to become universally accepted and a convenience in life and to make life that somehow diabetes technologies have not? And again, I hope I'm asking that in a clear way.
Yeah.
Do you see what the point I'm trying to make?
Yeah. No, it makes perfect sense. And I think there's a couple reasons. I think that, we've become essentially addicted to different smartphones and technologies because that it's positively reinforcing and that we get something by its use. We get continually, reinforced to use it. It's also extremely convenient when you can do things in and then you forget that it's so convenient to do it. So I think that there's the reinforcement side of it and there's the convenience side. Diabetes management tools, particularly devices and technologies, the whole notion, as you know, of diabetes is really about preventing bad things from happening, which is different than using these different smartphones and things like that, which is usually there's something positive about it. So it's a flipped, or it's kind of opposite in terms of the way that people are reinforced to use them. It's a lot easier for someone to use a smartphone than it is a diabetes device. And so I think that targeting a bit more on the convenience and integration with other aspects of life is really where people it's gonna resonate with them. So if it can, one, blend into the background a bit, they're gonna be more likely to use it. Just an app that's running versus something that they have to mess with a bunch of times a day. But I think that that's where the sweet spot is in helping increase use of devices, is thinking about convenience and removal of burdens and barriers versus trying to make them as positively reinforcing as phones and other technologies. I just don't think we'd ever compete with something like that. So those are a few thoughts on that.
If anybody has further questions, I think we could go on forever talking to you, Korey. But any specific questions before the top of the hour? Well, if not, Korey, really on behalf of the Diabetes Institute, thank you. We do want to see you back in person. There's so much more that we need to talk about, be it from quality of care, adherence, which I learned from Suzanne was not the same as compliance. Yeah. To really understand that, to really, understanding cost, to really understand exactly who's going to deliver care. I mean, there are so many questions, frankly, and discussion that I'm sure we will have more opportunities to discuss. So really with it, thank you so much, and be safe, and looking forward to seeing you in the new year. So thank you, everybody.
Thank you.
Thank you.
Thanks so much.
Thank you, Dr. Have a good day.